Hello, everyone. My name is Courtney Rinkevich, and I am so happy to welcome you to our 7th annual Cannabis in Practice webinar series. This series is hosted by the Washtenaw County Health Department, the Livingston County Health Department, in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for the series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. To review some housekeeping notes before we get started, all participants will be muted throughout the session. Please use the Q&A box to submit questions, which will be answered at the end of the presentation. If you require live transcription, select Show Captions function at the bottom of your screen. If you do not see it, please resize your window to be wider. This webinar is being recorded, and the recording and presentation slides will both be available on our website, washtenaw.org/marijuana, in the coming weeks. This live webinar has been approved for 1 credit hour of social work continuing education, 1 McBAP credit, 1 CHES credit, 1 Mishwa credit, and 1 CME credit. If you're requesting any of these continuing education credits, please be sure to stay until the end of the presentation to fill out a post-webinar evaluation survey. None of the speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. And now I am pleased to introduce today's speaker. Dr. Erin Bonar is a licensed clinical psychologist, the Kathy Bosnowski Research Professor in Behavioral Health Technology Innovations, and a professor with tenure in the Department of Psychiatry at the University of Michigan. She is the Director of Research Strategy for the Michigan Innovations in Addiction Care through Research and Education program. And Dr. Bonar studies ways to prevent and treat substance use disorders across the lifespan, with a particular expertise in addressing cannabis use. Her work uses novel technologies including social media, telemedicine, and patient portal approaches. Her intervention work often employs motivational interviewing, and she is a member of the Motivational Interviewing Network for Trainers. She is also the Cannabis and Substance Use Content Area Expert for the CDC-funded University of Michigan Injury Prevention Center, where she leads statewide efforts to evaluate the impact of recreational cannabis legalization in Michigan. And with that, please welcome Dr. Bonar.
All right, thank you. So I'm going to do this share, and hopefully folks can see, and I need to move Zoom controls around a little bit. You know how they always go where you don't want them.
They always do. It looks great on my end.
Okay, well, thank you all so much for inviting me. Oh, that's a new feature. I'm seeing a clap emoji on my screen, so they always like to add things when you don't expect it. So I'm going to talk today not so much about my work as a researcher and interventionist, but my sort of deep dive into trying to understand cannabis and how it's affecting people, and what some of the concerns may be. And this is a nuanced issue, and we'll get into it some. So as mentioned, I don't have any really relevant financial relationships related to this activity to disclose. And my work is supported by National Institutes of Health, CDC, PCORI, the Patient-Centered Outcomes Research Initiative, and of course internally through University of Michigan. And I also received generous philanthropic support from the Bosnowski family. So I want to include here today, and this, you'll have copies of these slides in case anything is hard to read, but these are 2 resources that I see as sort of my go-to for finding answers about cannabis. On the left is the National Academy of Sciences report on the health effects of cannabis. This is getting a little bit dated, but still is the most comprehensive sort of summary of what is known, pros and cons, or what's unknown about cannabis to this point. So it's still a very relevant resource, although we're doing more and more research on cannabis and hope to have this type of volume updated in the future. Another key resource is the National Survey on Drug Use and Health, which is a national epidemiological survey related to drug use and health and things like mental health. And I will show you results from that today, which highlight both in the United States, but also our state level results. And so things I show you for the state of Michigan are considered representative of our state. In addition, I've included a citation to an article led by Jason Connor, which is just a really great overview of, everything biological to social to what's the chemical parts of cannabis, what happens there to cannabis use disorder. It's a really great article, I feel is a great resource. I have a few disclaimers for this talk. First of all, when I'm showing you things that I'm going to tell you is the most up-to-date data, that data is still a few years old. That is just because some of the time it takes to assess things, clean data, distribute data, it takes time. And so we don't, there's a typo on my slide. We will have state level data for 2023, and that's some of the newest data. And that data was released in 2024. Also, I'm a clinical psychologist, so my expertise is really in psychology and the psychological and behavioral impacts, and less in the physical health pieces related to THC consumption or medical cannabis. So there may be many questions raised that I may not be able to answer. I want to give you all answers from my expertise. So although some of the data and the reports that we discussed today will show the term marijuana, I want to emphasize that our field is moving away from this, given the history of marijuana as a term used in Prohibition era propaganda that promoted racism and xenophobia. And so you'll see that to save time, I've used some slides or some images from other things that still use the term marijuana, but whenever possible, I use cannabis. I'm not going to get into the details of all the history there. If you'd like to know more information about this, the Guardian article that I'm showing you on, I think it's the right of your screen, maybe it's the left, but there's an article from the Guardian that does a really good breakdown of this issue. And there's a Library of Congress feature link there that has an interesting photo gallery and kind of a timeline of this issue. Suffice it to say, we'll be using the term cannabis as much as possible today. So then what is it? What is cannabis? And cannabis is actually a broad term for products that come from the cannabis sativa plant, which can include medical, recreational, and other industrial products. For the purposes of my time today with you, I'm really focused on psychoactive formulations of cannabis, specifically those that contain the cannabinoid THC, which is generally responsible for cannabis intoxication or getting people high. We won't be discussing really medical cannabis, only to say that there's little evidence of its efficacy for conditions like pain and mental health. There's some here and there, but it's certainly not more effective than existing well-tested treatments. And really, I'll just say that medical cannabis and its potential therapeutic applications needs to be studied way more closely. We're sort of behind the times in being able to study cannabis the way we have other substances. And we're not going to be talking about CBD. So CBD products are products that are from the plant, but they have no or very trace amounts of THC in them. There's a lot of interest in CBD for, again, potential therapeutic effects, and it doesn't tend to produce a euphoria or a high and has low potential for abuse or dependence. And so I'm really speaking to you about sort of the traditional cannabis that people think of as a recreational drug or something, that may be abused. So cannabis is the third most common controlled substance used by about 228 million people globally in the past year, or about 5% of people in the age range of 15 to 64. And there's about 24 million people who live with a cannabis use disorder. So let's zoom that in a little bit on our country, on the United States. And shown here, you can see that the majority of the population in the United States, ages 12 or older, so the gray part of this pie chart, most people don't use drugs. But there are about 61.8 million people in the United States that used cannabis in the past year, more so than other drugs that are of concern, perhaps things like prescription opioids or heroin that you've heard about more in the news. When you look at time trends for the United States in general, you can see that generally cannabis has been increasingly used by ages 12 and up, if you kind of lump everyone together over these past few decades. And that is illustrated by the sort of dark orange line. Now, breaking this down into age groups, adolescent use, which is here, ages 12 to 17, seems to be actually trending downward a little bit at most recently 11.3% of the having past year use, and that's the golden line. What we refer to as emerging adults or young adults ages 18 to 25, they're that sort of greenish line at the top. Their most recent prevalence of past year use was 37.4%. And then adults ages 26 and up, past year prevalence at 20.7% in the gray line in this figure. We can see from this National Survey on Drug Use and Health, which you may hear me call the NSDUH for short, we can see from NSDUH that cannabis is the third most common substance initiated annually, with 3.5 million people using cannabis for the first time in 2023. And that broke down to about 1.2 million adolescents, 1.2 million young adults, and 1.1 million adults over age 25. More than half of the 3.5 million people in 2023 who initiated cannabis use in the past year did so before the age of 21. So the past year initiation rate, or trying cannabis for the first time, this equates to someone new trying cannabis for the first time every 9 seconds in our country. And initiation rates have generally been increasing since around 2006 in the United States. You can see that line trending upward. And there's a break in the lines here on some of these figures because COVID, because 2020 was a year that complicated this survey, and some of the methodology changed after 2020. And so some of the results are not 100% comparable. But you can see the general trend here. So why do we care? Why am I talking about initiation of use? Well, the key here is that most initiation or starting to use cannabis really occurs in youth, teens and young adults who are still undergoing neuromaturational processes, which can be affected by regular cannabis consumption. So the median age of onset for cannabis use is about 18 or 19, but the mean is 15 or 16. And data shows that when individuals start using cannabis before age 16, they have increased risk for cannabis use disorder, and they can progress more quickly from use to disorder if they start using earlier. Additionally, onset before age 18 poses additional higher risks for things like motor vehicle crash, antisociality, polysubstance use, and school dropout. Further, there's a key issue that comes up with regard to legalization of cannabis use and whether it increases consumption among youth. That's a question that's still kind of open to be answered. But there is a recent review that is referenced here on this slide that sort of captures the nuances of this issue quite well. And so Struble and colleagues note that states with more permissive cannabis policies are associated with decreases in perceived risk or how risky people view cannabis to be. So when we sort of liberalize cannabis policies, make them looser, the more people start to believe there are no risks to cannabis use. And then when people believe there are no risks or very low risks, we tend to then see increases in adolescent use. This idea that maybe this isn't very risky, then you see more adolescent use. This can vary across locations and data sources. And of course, as we live in this landscape, we're going to learn more about these impacts as more and more states kind of join the green wave. And that's what I refer to it as. There's a green wave that's sweeping the nation. And just illustrating that here, this is showing you in the green states with the years when recreational legalization has come about and has increased since 2012 when we first saw Colorado and Washington legalize. And now only a couple of states do not have some sort of public access cannabis program of any sort. And while about half have moved to full recreational and adult use legalization. Here in Michigan, okay, in 2008, Michigan legalized medical cannabis. And most here probably know that over the past few decades, there's really been a proliferation in these medical and recreational efforts, legalization efforts nationally. So in November 2018, here in Michigan, we became the 10th state and the first in the Midwest to pass a recreational cannabis law, creating the Michigan Regulation and Taxation of Marijuana Act with a vote. And actually, the vote was 56 to 44%. So, of course, as I was watching the election results roll in that night, 2018 was a big year. I couldn't believe my eyes when I saw the error made by the graphic staff. So, as we know, or maybe you don't know, but cannabis can impair things like coordination and maybe the functions you need to enter data on election night. And so I had a feeling I knew which way our graphic staffer at Local 4 out of Detroit voted when they displayed this sort of impossibility that 79 people could vote no, while 99% vote yes. Like more than 100% of people voted here. So I think that's just, such a kind of encapsulates some of the concerns about cannabis use and just couldn't believe my eyes. But regardless of this, again, 56 to 44%, this law went into effect in December 2018. And recreational dispensaries, they opened about a year later in December 2019. You can see here that recreational cannabis dispensaries have proliferated across the state. And although various individual counties or localities do have jurisdiction and can decide not to allow cannabis facilities or dispensaries, you can see just from the snapshot that they're quite accessible to people. And some of our recent data show over 800 sales and consumption establishments in the state. And it's probably a little bit more now because that was data from Q3 of 2024. Cannabis sales are a huge industry with the most recent data shown here topping out, or I don't have the data shown actually, but I'll tell you later where you can get it. But about 250 million in sales per month. And so here and in many other places, but here in Michigan, as this green wave is sort of coming over the country, there are signs of cannabis all around us. Literally. If you've left your homes in the past 5 years, you probably noticed cannabis-related advertising throughout our state. I, kind of notice this a lot when I am driving. I drive south to visit family who, I come back up through Ohio into Michigan. And until Ohio legalized, there were definitely cannabis signs welcoming me home at the border. And, these are just two side by side that I took in downtown Ann Arbor, demonstrating the dispensary advertising right next to some very strategically placed public health messaging during COVID. So I appreciated the cleverness there. Again, huge industry, and we are, as a state, again, according to the most recent data, the second largest job market for cannabis behind California. And we have gained the most jobs in cannabis in 2024. The industry is growing and transforming. For example, there are now a few cannabis consumption lounges in our state where people can partake in cannabis together in a social space. And so there's not a ton of these, but there are a few around. So zooming in on Michigan and our state, this is what we look like. The most recent state level data, again, from 2023. And in Michigan, 27.1% of our population used cannabis in the past year. The lowest state in the union was Iowa at 15.5%, and Vermont was highest at 34.3%. When we look at use rates in Michigan over time, that's the golden line. You can see that we, as a state, outpace the Midwest, which is the dark line, and the US as a whole, the darker orange line. So we are always ahead, and we started to pull away a little faster pre-COVID. Now, in terms of past month consumption, which is what epidemiologists define as current use, nearly 20% of our state residents ages 12 and older have used cannabis in the past month. And so when you take those people who used in the past year, it works out to about 72% of them are using currently or in the past month. So that's a large chunk. The lowest state in the union now for this metric is Texas at 10%, and again, Vermont highest at a quarter of their state using regularly. Similar to the annual data I showed you in terms of current use, Michigan in gold is again outpacing the Midwest, that darker line, and the US as a whole in the orange line. So you can see that, we're kind of 4 to 5% ahead of the United States and Midwest in terms of current use. Here's that use past month current use data broken down by age groups. And over time, use has remained sort of relatively stable or declined a bit in 12 to 17-year-olds, the gold line. Adults who are over age 26 and emerging adults 18 to 25, they had been rising in recent years, as shown in the gray and green lines respectively. And although I don't have state level data on this, we are seeing national trends increasing in terms of increased daily use of cannabis, particularly in the younger age group. This is really a cause for concern, again, because of those neuromaturational changes that are happening as the brain is developing. So if you're in practice and you see young adults in your practice, it's possible that, around, let's say, 1 in 3 almost are currently using cannabis. And I'll get into more details as to why that may be a bit of a concern as we continue. One thing is the national data and the state level data that I have typically doesn't break apart the adult age group. It's like once you're 26, there's no more like detailed fine-grained data. But through the Institute for Healthcare Policy and Innovation at Michigan and in partnership with AARP, we were able to do some data collection, again, representative for the state on older adults ages 50 and over. And I'll say as I get closer to 50, I'm like, really? Are we calling that older adulthood? And, we'd like to maybe still see this still more fine-grained. But what we found among our older adults, and this was actually in 2024, 27% in our state used cannabis in the past year. 9% use weekly, 5% use daily. And among those who are using, what I'd say at least monthly, we found that about a quarter had driven within 2 hours of consumption, which is, a time when cannabis could be impacting the person's functioning. And we saw some signs that are a little bit, concerning in terms of 35% saying they've experienced tolerance, which is a key marker for a substance use disorder, and 12% experiencing strong cravings, another key symptom. We asked our older adults why, what are some of the reasons to use cannabis? And I think it's really important to point out here that people are using cannabis for valid reasons. They want to feel better, either for help with relaxation or sleep, pain relief, or to cope with mental health symptoms or mood, as well as, just potentially enjoying the high effects. So, that there's not wrong reasons here that people are, sort of trying to feel something and feel better with things that are bothering them a lot of the time. A couple other populations I want to highlight or other snapshots. This is in pregnant women or Michigan's mothers. And we were able to partnership with the MDHHS and the PRAMS monitoring survey, annual survey of pregnant people in Michigan. And what you see here is 2 columns about cannabis use before recreational legalization, a snapshot in 2016 and 17, compared to after recreational legalization, so a snapshot in 21, 22. And we see that before legalization, about 3% of Michigan's mothers, so people pregnant during that year, giving birth during that year, 3% use cannabis during their pregnancy. And that figure after legalization has tripled to 9%. And so that's a concerning figure. Most pregnant people don't use cannabis, but we're seeing an increase in cannabis use in this population in our state. And as I alluded to earlier, but here's a figure illustrating it. This is actually national data up through 2022. The green line is cannabis and the red line is alcohol. And by 2022, there's more people using cannabis daily in the United States than alcohol, which, is often something that we compare cannabis to because it's our other sort of socially acceptable, legal drug or substance that's very common in our country. So that's a lot of the context regarding the epidemiology of cannabis and the surrounding industry, and I want to try to dive a little bit more into the drug itself. So this is a quick pictorial of what cannabis does to the body. So THC activates cannabinoid receptors located throughout our body, particularly those in the more cognitive and motor areas of the brain. And it also can impact things like immune and GI systems. And it causes a lot of complex actions on the different neurotransmitters that are released in our brain and resulting in effects on cognition, memory, motor, mood, and so on. And so that's my cursory overview as someone who's not a neuroscientist. One of the things I want to point out, though, is that you do not in this image see a lot of things pointing at or see a lot of activity in the brainstem region. So with cannabis, we're less concerned about respiratory depression leading to overdose the way we are with other substances that, are also a concern, like opioids. So at the same time, although we need to be aware that the lethality of cannabis use is different than other substances, that there are things to be concerned about with cannabis, namely cannabis use disorder. And I'll talk more about that in a few moments. So to understand risk for cannabis use disorder in current society, it's important to know more about the products people are using and how those can potentially amplify risk. So I always say, today's cannabis is not your mother's Mary Jane. There are a variety in products and modalities for using cannabis that are available, especially through this retail market. So if you go to a website for a dispensary, you'll see a product classification that mostly looks like this. So in addition to flower or sort of traditional bud, we now have vaping oils, we have tinctures, we have topicals, concentrates for dabbing like wax or shatter, and of course edibles. Most people tend to still smoke cannabis as the most common way to consume it, but you can actually see here, because these numbers add up to over 100%, that people use a variety of modalities and that a lot of folks use not only smoke, but also use edibles or vape and then more and more are dabbing. So, this is still smoking is the most common, but we're seeing the emergence of other types of products and people be multi-product users. To me, the edible market is specifically interesting because the foods can be packaged in a way that is appealing to youth and adults alike. As you can see, there are a number of products that look like junk food or candy to maybe some of our more high-end looking fruit candies and peanut butter and olive oil. And they're really products that are made to appeal to a variety of aesthetics. For example, the dispensary that's right next to my local Starbucks advertises their sustainably grown, organic, essentially farm-to-table cannabis products. And so I live in Ann Arbor, they might be trying to appeal to an Ann Arbor demographic there. It's just products out there for everyone. Another important modality to be aware of are dabs, or highly potent products, which are concentrated butane hash oil. Dabs can look a bit like earwax or a rock candy, as you see here, and they're consumed by pulling off just a small piece, maybe the size of a Tic Tac or smaller, and heating it up to a very high temperature using a very specifically designed glass bong, commonly called a rig or an oil rig, and then the vapors are inhaled. Dabs are very, very concentrated forms of THC, and they've been shown to have a number of adverse outcomes. One study found that dabbing can lead to higher tolerance and worse withdrawal symptoms. Vaping is also a newer modality of cannabis use. Typically, vapes involve a concentrate, so similar to like an e-cig or a Juul, although there are also dry vapes that use flower. Vaping is different than smoking in that it does not involve combustion, so it typically lacks some of the toxic byproducts that accompany combustion. Thus, in some ways, it's perceived to be safer than smoking, but there's other effects going on here, and that vaping usually has greater subjective effects, and the cognitive and psychomotor impairment tend to last longer. And there's, these other chemicals in vapes that you don't necessarily find when smoking. So there's some sort of trade-offs one may consider there. And you've heard me maybe start to reference a few times so far, maybe that some of these products of today have higher potency. When I say that, I mean that the percentage of the product that is composed of THC. And although the numbers are not directly comparable, you can think of potency as similar to the ABV rating you have for alcohol. So a greater percentage of THC means that cannabis is stronger. And so there are a few papers here I've borrowed the figures from by researcher Dr. El Soli, and these demonstrate how potency is changing in U.S. cannabis. These graphs are from papers that look at the average THC content in cannabis seized by the DEA. So in the 1990s, the average was about 4%. It was fairly weak, if you will. And that tripled by 2014 when the data for the first paper was obtained, the graph on your left. In a follow-up paper, this actually increased to an average of 14% by 2019. But this is key because it's only reflective of DEA seized cannabis and not necessarily the cannabis that is available on our retail market, which can average as high as 70% for dabs, for example. And anywhere you can find flower anywhere 20 to 50%. So I really mean it when I say the cannabis of today, that is not the cannabis a lot of us grew up with, or the cannabis of the 90s. That the cannabis being used today is much, much stronger than it used to be. And a growing scientific literature is really beginning to identify risks specific to this higher potency cannabis, such as increased rates of cannabis use disorder among people who use concentrates, and impaired executive function and inhibitory motor control for those who smoke higher potency cannabis. So by no means is this a perfect analogy, but the analogy that I use to think about how strong these products are. For example, our flower from the 1990s, you can think of that as like a Bud Light. It's pretty weak stuff. You have to have a lot of it to have a lot of impact. Whereas flower today, that really ranges. That can be something like your Bell's Two Hearted, which is a higher alcohol beer, a stronger beer, to a glass of wine, or even a shot of liquor. So flower can be all over the place. Vapes and edibles, they tend to end up on that stronger end of the range. And so I kind of think of them as they're like your strong mixed drink. They're your Long Island iced tea. And then dabs and concentrates, those are the strongest. Those are your Everclear. Those are your grain alcohol. That's the stuff that's really strong that I remember kids in college being like, oh, we're going to get some Everclear and get really messed up tonight. And then, saying never again after that. So just to put it into context of maybe other products you're more familiar with. And really the important point I want to make here is that something we see over and over again with different substances that become abused, which is as they are made stronger and more potent, there is a greater potential for addiction or substance use disorder. And it's really critical to note that at the same time that we are seeing cannabis become more potent, we're also seeing more and more people indicate that they feel there are no harms associated with cannabis use. And that's sort of shown in the graph on the left, which is now a few years old. But as cannabis is overwhelmingly now seen as less risky than other substances, there's something a little bit problematic or challenging about that view, which is true in some respects. Again, we talked about, people aren't overdosing and dying from cannabis, but they are experiencing other problems. And what happens is people view, as we tend to start to think of something as low risk, we start to equate that with no risk. And so we're seeing actually that people are seeing this as not very risky at a time when the potential risks of cannabis are actually increasing as it gets stronger. And so importantly, young adults, again, those ones that their brains are still forming, they continue to have the lowest levels of perceived risk for cannabis use. And as I've mentioned, one of the key risks associated with cannabis use is cannabis use disorder. And I want to make an important point here that is true across substances. And it's that the majority of people who use a substance, including cannabis, will not experience major problems related to their use. However, for some, cannabis can have critical effects due to short-term or long-term and heavy use. And, I'm here today to share about this information, not as a scare tactic, but to say, hey, this is real. Here's what it looks like. Here are some potential things that we can do about it. But some of the effects, and this is an article from Dr. Nora Volkov, who is the director of our National Institute on Drug Abuse, and she published this with colleagues in the New England Journal of Medicine. We see effects of short-term use being impaired memory, impaired motor coordination, altered judgment, and in some high doses, paranoia and psychosis. Of course, effects of longer term and more heavy, consistent use are addiction, altering brain development, negative educational outcomes, cognitive impairment, diminished life satisfaction, and achievement, which are some of the key ones that I care about for people as a psychologist, is well-being and living your life as in the way that you want it to look. And then we see some other chronic risks as well. In terms of consequences, a recent meta-analysis showed that 22% of people who use cannabis have a cannabis use disorder. So that's about 1 in 5. So it's pretty common, given especially as cannabis use becomes more common. And when people start using in their teens, their risk is heightened, and it's 33% among young adults who use regularly, and anywhere between 25 and 50%, that's what studies are showing now, for people who use daily. Cannabis use disorder it's a serious psychiatric condition, and it involves the continued use of cannabis despite impairment in psychological, physical, and or social functioning. And we have symptom criteria based on the DSM-5, with the 11 symptoms shown here, a minimum of 2 meeting criteria for mild cannabis use disorder. These symptoms, again, reflect impaired control, increasing priority of cannabis, resulting in social or physical risk, and the physiological signs of dependence, which are tolerance and withdrawal. In the US, 17% of the population meets criteria for a substance use disorder. Of people with substance use disorders, 27.2 million have a drug use disorder. Of those people with a drug use disorder, cannabis use disorder is by far the most common, accounts for about 39% of drug use disorders. We can see here across ages that 18 to 25 group is spiking in the green for cannabis use disorder, and generally the prevalence across all ages and different age groups relative to, again, I didn't pick these comparisons, but other drugs you may be hearing about in your practice or in the news. Cannabis use disorder, or CUD, has been increasing in prevalence as well. Shown here is a stark increase in difference across ages for a 10-year period. The dark blue showing 2023 compared to the maize or yellow showing 2013. And all of the things that have happened in this decade have included much greater access through legalization, the continued increasing availability of higher potency products, and a mental health crisis. There's a wide range of biological, psychological, and social factors that shape an individual's vulnerability to cannabis use and cannabis use disorder. And repeated exposure to sufficiently high doses of THC for an extended period can result in adverse, acute, and long-term mental health, physical, and social consequences. Further, we're seeing that potency and frequency of use matter with regard to CUD risk. And remember, I showed you that graph for potency increasing since the 90s. So in 1992, lifetime risk was 9%. Now it is 30%. Vaping among youth, as well as other high potency modalities, is driving increased concern about these rates, in addition to risk for CUD consequences as frequency of use increases. And this is really critical because, as I showed you, frequency of daily use is increasing. And so I mentioned withdrawal. I'm going to touch on withdrawal for the clinical audience here. This is related to a common myth I hear about cannabis. And people say, well, cannabis is not addictive. How can it be addictive? It's natural, it's plant, it's not addictive. They say people can't experience dependence and the associated withdrawal. And that's simply not true. Evidence supports that the key facets of addiction, tolerance, and withdrawal do occur with prolonged cannabis use. The issue is that the major drivers of withdrawal are mood and behavioral symptoms, as opposed to the other more physiological symptoms seen with alcohol and other drugs. Here you can see the symptoms of cannabis withdrawal, which can include, after cessation, feeling irritable, nervous, anxious, trouble sleeping, changes in appetite, restlessness, depressed mood, and some other physical symptoms. So as a practical point, if you have a patient in your practice presenting with these types of complaints, given the rates of cannabis use in our communities, it could be important to rule out or rule in asking about their cannabis use and whether they use or if they've made any changes to their use recently, which could result in these symptoms. And I want to point out that cannabis use disorder can carry risk for several comorbidities as well. So we're seeing with cannabis use disorder higher rates of mood, anxiety disorders, and other substance use disorders. And on the flip side, among people who have other diagnoses that you can come across in your experiences, there's an increased risk for cannabis use disorder. This figure here illustrates how most of the general population actually abstains or engages in low-risk use. These are not folks that need treatment or interventions. Prevention is doing its job. Working up the pyramid, though, there are fewer people in each level, but there's an increasing level of problem severity and a higher level of treatment need. This is coupled with low rates of treatment seeking and other barriers to treatment like access and affordability. The U.S. Preventive Services Task Force, if it still exists, or at least when it did, they recommend routine screening for cannabis use problems as part of primary care. Good clinical practice indicates that, regardless of setting, actually, we should be asking about cannabis separate from other drugs. So when you ask a patient, do you use any drugs? That complicates the picture for those who don't view cannabis as a drug, maybe because they've heard it's medical or because they feel it's natural, like supplements or something. And so it's important to ask, really more specifically, like, tell me about cannabis use. Does it have a role in your life? Or what does that look like for you? Not those yes or no questions that people say no to quickly move on from. And at a minimum, if someone is using cannabis, it's recommended to assess quantity, frequency, and how they use it or mode of administration. It can also be helpful to understand potency, how strong the products are that they're using if they have that information. If they're buying from the legal market, there are estimates of potency on all products. And that can really facilitate a harm reduction approach for folks, like cutting back their dosage for those needing to cut back. And again, the pet products will have labels on them that are estimated and tested. But one of the key things to, I think, keep in mind just by asking about cannabis use in your patients and in your practice is it can really start to normalize bringing it up as a part of routine care, just like we ask everyone about, their alcohol use or, various, are you having this type of pain or that? We can make that normal and routine to help us pick up on problems more often when they are there. So in terms of practical advice of how to start this and bring this up into conversation, you can simply start by asking how often a person used cannabis in the past year. It's a single item that's more effective than using any sort of multi-item scales. And it seems to be that if someone is using more than occasionally, then inquiring more and just getting a picture of how cannabis is working in their life can tell you what's going on with them and whether they're using for reasons that may be best addressed by another type of treatment or another approach. Following up with a symptom checklist for diagnostic criteria can be used to guide patient-centered conversations about concerns about their use and other ways to potentially address motives for use. This will be in your slides, so I'm not going to spend a lot of time on this, but there are suggestions from the New England article of a more thorough assessment, a comprehensive assessment for CUD, but this is more likely to just occur in a substance use or mental health treatment setting. Another tool that may be helpful, and this is easily Googleable if you don't grab it from the slides, is Cannabis Use Disorder Identification Test, which is free and publicly available. And the items mostly reflect CUD symptoms. And so if this is administered and a person scores at least 13, that can be highly indicative of a cannabis use disorder. So I want to share some ideas that can be used when working with someone to reduce harm associated with cannabis use. These are guidelines, these are out of Canada. So the United States hasn't really adopted any sort of guidelines for low risk use, but our neighbors to the north have. This is similar to thinking about other low risk guidelines that we develop for other health behaviors. The guidelines assume that individuals who continue to use cannabis despite advice to cut back or abstain, they might be prepared to at least modify their use to minimize harms, including risk for CUD. These guidelines include ideas like using lower potency products, limiting days of use or times of day, and so on. And additionally, before I jump to another topic of driving, another strategy that can be useful is called a tolerance break or a T break. And this is a period of time when a cannabis using individual abstains for several days or a few weeks in order to reset their tolerance to avoid gaining too high of a tolerance. So another thing I find important to cover with patients is their understanding of cannabis and driving, and the recommendation not to drive for several hours after consuming cannabis. And honestly, that impairment from cannabis is really attached to how often you use, how much, and what strength of product. And so that's really hard to give a really specific guideline. But in Michigan, there's actually no safe, determined level of THC that people can have in their bloods and not incur legal consequences. They can have consequences legally if cannabis is in their body when they have an infraction, whether they used or were high at the time or not. And, clinically, I worked in my clinical areas in actual substance use and mental health treatment. And many people tell me that they feel like they're better drivers when they use cannabis, that they slow down and they pay attention more, and that being a little paranoid means that they're looking out, that they won't get caught. And objectively, though, we know cannabis impairs coordination and reaction time. And so the analogy that I often use putting this into context is that, we all have seen the PSAs or we've seen this happen. We know the drunk driver. The drunk driver, after using alcohol, is swerving. They're blowing through the red light at high speeds. They're driving in the wrong lane, things like that. The high driver, the driver that's used cannabis, they're sitting at the stop sign waiting for it to turn green. So it's a different impact. And the impacts are very subtle. So it's those moments where we need to react quickly that cannabis can make things more slow. So one of the things you can do as a provider with individuals who use cannabis is to plant some seeds that might alter conceptions about the risk of driving. This is something that, again, people have misconceptions about, but the goal is not to start an argument. And it's not to be corrective. People don't like being told what to do, even when we're well-meaning. And so I often address this topic with people using a tool from motivational interviewing called elicit, provide, and elicit. And so the first part of eliciting is first asking what people know. What do they think? Because you don't want to tell them things they already know and they'll tune out. So we elicit, something along the lines of, what do you know about some of the possible risks of driving after using cannabis? It's an open question. They can say, I don't know much, or I don't think it is risky, or, whatever they say, you can either validate things that are correct, or you can, reflect, oh, okay, that's interesting. And then you can provide some education. Sometimes people are surprised when they learn that cannabis slows down their reaction time and coordination, that these are actually really, really subtle effects, but that they matter when something unpredictable happens. Like, and we all, I think maybe not all, but a lot of us probably live here in Michigan, and we've had a deer jump out in the road. And those are the moments when a bicyclist pops out of nowhere and you have to throw on your brakes or you have to swerve. When you need to react quickly and milliseconds matter, that's what cannabis can slow down. And that's the sort of scary part about it. So after I share that, I always want to know more about what they think about that. Like, what do you make of that? And how do you make sure you're getting around safely? So we can start to elicit from them ways to avoid driving or stay safe. Finally, another note, as I'm getting close to wrapping up here, a note on risk reduction that you can talk to your patients about is if they have kids at home or pets actually, to make sure they're, keeping their cannabis locked up safely to avoid accidental ingestion by children, especially because, again, those products can sometimes look very appealing to kids. And in fact, one of the things that happens after legalization of cannabis in a state is that there tends to be a sharp increase in emergency department visits and poison control calls due to ingestion of highly potent products by kids. And we've actually seen this here in Michigan. This is data from our collaborators at Wayne State and the Michigan Poison Control Center. And first of all, we see that over time, since legalization and since medical legalization for sure, we've seen an increase in what proportion of calls to the Poison Center are about cannabis. And then that increase is the graph in the bottom, sort of the takeaway from that is that increase is driven by increases in children younger than age of 12, that we are seeing, especially since legalization recreationally, more poison control calls for cannabis ingested by kids. Finally, another option for individuals to reduce their risk of cannabis use is to review and engage in some protective strategies. You can see a list here. You can have this on the slides, and these are designed to limit consumption or avoid harms, like avoiding using at certain times of day, limiting use in public, and so on. And in terms of cannabis use disorder, there are effective treatments available, shown here in a recent meta-analysis and summary of the literature. By far, the best evidence supports cognitive behavioral therapy and or motivational interviewing, also called motivational enhancement. Contingency management is also supported very well, but is not widely available. There's limited evidence that these other approaches that are also shown are effective. We need more studies, but generally things like mutual help group, not as effective as these psychosocial treatments. It's important to keep in mind, like other drugs and alcohol, that most patients don't reach sustained abstinence, which is often not their treatment goal. And the goal of therapy really should be to increase duration of abstinence, decrease frequency of use, or to reduce symptoms and improve psychosocial functioning. Just quickly, I'll say, because I want to leave that little bit of time for questions, and I realize we're getting there. So that there aren't really approved medications. There's not a naltrexone for CUD. There is not a drug that we feel is most effective yet. That this needs to be studied more. It'd be great to have a medication option to help folks. There are some substances that are used, or prescriptions, I should say, that are useful in mitigating withdrawal symptoms, or it can also be very, very important to, treat the mental health symptoms that might be co-occurring with CUD, and that medications for that can help those things that then give the person more of a impetus to work on the cannabis use. And so finally, in terms of what I hope to conclude and have you walk away with as you think more about cannabis use in your practice, it's just to keep in mind that cannabis use is increasing. Potency is increasing, yet most people view cannabis as harmless. And given the relationship between potency and CUD onset, we need to think about prevention approaches, but also to be prepared to manage CUD clinically. However, the best treatments studied to date involve cognitive behavioral therapy and motivational enhancement or interviewing. And the really good news is that those are treatments that are widely implemented in other areas, and they're likely a known skill set to many clinicians. And treatment can be located through insurance networks or the SAMHSA treatment locator found here. The last thing, this is a total aside, but it was mentioned earlier that I'm the cannabis content expert for our University of Michigan Injury Prevention Center. We have worked with partners over the past year or so to gather data across areas of well-being, criminal justice, different things related to cannabis impact in our state of Michigan. We are releasing our full report of a sort of before and after legalization, and it's available at this QR code if you want to see a holistic picture of all the different ways that we're seeing cannabis sort of materialize in our state. It's in final drafting form now at this QR code. You might see a fancier version uploaded later as well. With that, I want to thank you all for your time and attention, letting me go through these topics, and I'm happy to attempt to answer any questions that y'all may have.
Thank you for that wonderful presentation, Dr. Bonar. We're now going to open it up for questions. We do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. And as a reminder, this webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. So transitioning over to some of the questions that we have, one of our participants asked, can infants, adolescents, or young adults who do not use marijuana but live with regular users experience psychological effects from secondhand marijuana smoke?
A great question. I think that's one that definitely gets into the toxicology and a little outside of my wheelhouse as a psychologist. I think that generally speaking, that'd be a great question to ask a physician. The issue with any smoke, though, is that it can impact the people that are breathing it in. And so, if someone's using cannabis in the home, it would be recommended that they go outside.
Thank you. Do you find it helpful to suggest that clients change their method of cannabis use as a means of harm reduction with the eventual goal of complete abstinence?
That's also a great question. I think any treatment of cannabis use disorder has to be really personalized to the person, or even just what do we know about what they're using, how are they using it, and what are ways to cut that back. And so you may find that someone who is smoking a lot throughout the day, perhaps then having a low dose edible at night or something would be safer for them. They're not smoking then, and it really has to be sort of tailored and targeted to the person. And again, thinking about any change we make. Okay, behavior change is hard. I don't know if people have ever tried to diet. If you're not a big exerciser, try to exercise or try to break a habit like biting your nails. things that we can all relate to. The stuff is hard. And so just like having the patience to try different things, try different options, with the overall goal of reducing and cutting back on that risk and chipping away at it.
Thank you. I can definitely relate to the behavior change is hard in very many different domains. It's similar to that question. I imagine that your answer will also be similar. Someone asks if you would also recommend changing dosage, i.e. like in the example was given with alcohol, they might ask their client, you know, how much and like what type of drinks are they having, but they're a bit lost about what to do if their patient says, I take a 400 milligram edible or XYZ. It's hard for them to know what that means.
Yeah. And so wherever the starting point is, reducing from there, right? And so, because right now it's not like our nutrition labels on food where we're getting the recommended daily amount of something, like you get 2,000 calories or an average person does. There's not a recommended daily amount of cannabis. The recommendation is probably 0 for most of the circumstances in life. And so even if you're not familiar with the dosage, knowing what it is and cutting back from there would be a reasonable place to start. Have people take pictures of their products and show you. I don't want to say, bring your weed to the doctor's office, but people, everyone has these tools now where they can track information or keep track of these things. So, having being able to look at what they're using and look at it and learn a bit about it may help as well.
Got it. Okay. Our next person says, thank you for including the cannabis use by older adults slide. Do you know of any other research specific to older adults cannabis use, like cognitive effects or memory issues?
One of the things right now, I just wrote and got reviews back on a paper about cannabis impaired driving among older adults. And one of the things that I noticed in what some of the reviewers had said were they pointed out other studies to me that I didn't know about. And I wish I knew what those were now. I'm happy to, have folks email me and I'll share them. But I would say right now, there are studies that are looking at things like cognitive impairment. They can, they're starting to be able to bring people into the labs and administer cannabis and do tasks and things. And so with some of the loosening on restrictions around cannabis research, that is starting to pick up. We're behind the times on being able to really do those studies though, because there is a lot of federal red tape around studying it the way people have studied alcohol and the way that people have studied, the medications. So it's not advised though, right? So you already know as an older adult, it gets harder. All the things slow down. And so adding something that slows things down wouldn't be advisable. And that's what cannabis tends to do.
Thank you for sharing. That was all the time that we have left for questions. I want to thank you again, Dr. Bonar, and thank you all for attending today's webinar. We would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. Please use the link in the chat or the QR code on the slide to complete our feedback survey. As a reminder, this live webinar has been approved for 1 social work credit, 1 McBath credit, 1 Mutual credit, 1 CHES credit, and 1 CME credit. If you're requesting any of these continuing education credits, you must fill out the evaluation form with your name and email address. This webinar concludes our 2025 Cannabis in Practice webinar series. We hope you found this webinar series informative and interesting. For recordings of this year's and previous year's webinars, as well as more information, visit our main marijuana page at washtenaw.org/marijuana. And we thank you all for your participation. I'll hang out here for a couple more minutes so folks can use the QR code or the link in the chat. But beyond that, thank you all for coming.
Thank you so much.